So when we take these measurements that were performed on September 24th, these are the initial measurements at 40 weeks, and the fetal weight came out 9 pounds 10 ounces, or almost 4,400 grams, in the 96th percentile. And at our institution, patients whose weights are above 5,000 grams are sent directly to cesarean section for macrosomia, and fetuses whose weights are at 4,500 grams will go directly to C-section if they are gestational diabetics. So this patient is flirting with the possibility of a primary cesarean section without even a trial of labor because of the size of this fetus. With the more accurate measurements, we see that the weight is actually or possibly 8 pounds and 5 ounces, which is in the 74th percentile, not the 96th percentile. Okay, well, what's the answer? 9 pounds and 10 ounces, or 8 pounds and 5 ounces. The patient delivered on October 3rd, which was 9 days later, and we do understand that fetuses gain approximately a half a pound a week. So that the true weight of this fetus approximately 9 days later was 8 pounds and 11 ounces, a little bit more than a half a pound larger than we had estimated with the accurate measurements, reminding us all that the correct measurement technique is critical. Moving into the second portion of the talk, discussing fetal anatomy, we're going to start with looking at mistakes to avoid when imaging the fetal head. One thing that it's important to avoid is describing normal anatomic variants as pathology. And here I'm showing you an example of the cavum vergae. The cavum vergae is a posterior extension of the cavum septum pellucidum. It's seen in the midline between the lateral ventricles, and it can be seen here underneath the corpus callosum on the sagittal view. When the cavum vergae extends posteriorly, it's termed the cavum velum interpositum, and here we see it earlier on in the midline at 19 weeks, and on the sagittal image at the posterior aspect of the corpus callosum, a little tiny cavum velum interpositum. A normal variant. It does not need to be even included in the ultrasound report. Remember that everything cystic in the brain is not a normal variant. In this case, we have an irregular fluid collection that's right in the midline, but has a curved shape to it and possibly some extensions out of this shape. And don't forget to turn on the color Doppler in this instance, because we see that this is a large vein of Galen aneurysm. Another cystic thing in the brain is this round structure here. It is not in the midline, it's off-center on one side. It's posteriorly and related to the tentorium, seen underneath the temporal occipital lobe region here, and this is an arachnoid cyst. It's important when looking at the fetal head to spend some time looking at the lateral ventricles and not to overcall ventriculomegaly. The plane of imaging to measure a lateral ventricle must be level. Any off-axis measurement will increase the size of the ventricle. It's important to mark this, to put the calipers exactly where the edge of the lateral ventricle is, just on the inside of the ventricular lining, and be careful not to measure the medial surface of the brain rather than the medial wall of the ventricle. And remember, we can assume that the ventricles are symmetric unless you visualize asymmetry. Always use the smallest technically accurate measurement. Any measurement that you take of the lateral ventricle that is artificially increased is due to measuring this ventricle obliquely, so that the true measurement, the smallest measurement you get, is the true measurement. It's impossible to measure a dilated ventricle as smaller than it truly is, but it is possible to take a normal-sized ventricle and make it larger. The other thing that you can look at that might help you is the presence of a dangling choroid. The choroid should typically completely fill the lateral ventricle. If there is more than 3 millimeters of space between the medial wall of the ventricle and the choroid plexus, this suggests ventriculomegaly. And this is particularly useful early in pregnancy, but should be monitored rather than diagnosed as abnormal. Here's an example of how to correctly measure the lateral ventricles. This is the down ventricle, and we see a choroid here, and then the calipers sit in the atrium of the lateral ventricle along the medial edge here and the lateral edge here. an example of the dangling choroid, where the choroid is separated from the medial wall of the lateral ventricle, and we can measure this distance from here to here, and if you see as much as 3 millimeters, it suggests that there is underlying ventriculomegaly. And again, this is useful early in gestation where the 10 millimeter cutoff might be a little bit too big. Well, why does it matter? Here's an example of a fetus where we were measuring both right and lateral ventricles, and clearly there's hydrocephalus. There's no question that these ventricles are dilated. But if you notice on this up ventricle, the measurement is 33 millimeters, but here's the falx. And the presence of the falx in the back third of the head tells me that we're oblique through the head. The falx should be running right down the middle. So we have artificially increased the size of this lateral ventricle. Here's the same fetus in the down ventricle, and we have also artificially increased the size of the ventricle to 36 millimeters because we've crossed the midline, and this is at least part of the third ventricle and possibly part of the up ventricle that's being measured as well. More accurate measurements for this fetus: the falx is right down in the midline, and we're back in the atrium, and we have a measurement of 24 millimeters. And on the downside, again, here's the dangling choroid, the medial aspect of the ventricle and the lateral aspect of the ventricle, 25 millimeters. Why is this important? Well, this fetus is being monitored for progression of the hydrocephalus because of the presence of a lumbosacral meningomyelocele seen here on the sagittal view and seen on the clip and the transverse view with the open posterior elements. And the patient's obstetrician is using the size of the ventricle to determine whether this fetus is stable or whether there needs to be an intervention because of progressive ventriculomegaly. A few words about choroid plexus cysts. These occur in less than 1% of fetuses and are associated with trisomy 18, but as we know, choroid plexus cysts are often a transient normal finding. And when we see a choroid plexus cyst, it probably is more often normal statistically than associated with trisomy 18. Choroid plexus cysts are discrete, round, anechoic structures. They should measure over 2 millimeters, and they should be completely within the choroid. In addition, you ought to be able to turn on a choroid plexus cyst and see it in every plane of imaging. When cysts are overcalled mistakenly, it's typically because it's not a true cyst. The lesion is not round in 3 planes, and it more likely is something that we call a spongy choroid. So here are 2 different patients with choroid plexus cysts. This is much earlier in gestation, and there's the round, black, discrete structure completely within the echogenic choroid plexus cyst in this fetus with trisomy 18. Here's a different fetus. The choroid plexus cyst is much larger. Indeed, it almost replaces the entire choroid. In this fetus had normal chromosomes. Compare those discrete black circles to these 2 fetuses who have a more smudgy, irregular, ill-defined sort of blackness throughout the choroid plexus, but no discrete, well-defined sphere on either one. And these have been termed the spongy choroid, but a spongy choroid is a normal choroid. It does not need to be put into the report, and this head and this head are both normal.